Welcome back to Mice TV, live in studio in Da Nang. We are here with Brooke and Dr. Sheetal Brar, who is a cataract and refractive surgeon from Nethradhama Superspeciality Eye Hospital in Bangalore, India. Good morning, Dr. Brar. Welcome to the show.
Good morning.
So one question, you were out there late with the crew last night. How do you feel this morning?
By the way, was that me?
It was you, yeah, and I think you were involved in...
You sure there's no doppelganger of mine going around in this meeting?
Oh no, I don't know.
I'm a serious ophthalmologist, an academician.
Yeah.
I don't push people in pool.
Cake and Pie Expo 2.0. Cake and Pie Expo. Come on, you know you want
No, totally not. So did the other Dr. Brar have a good time last night?
You can ask her.
Yeah. So, you are a cataract and refractive surgeon, is that right? And we're going to be talking about Phaco versus Femto today.
Yep.
So, tell me a little bit about that topic. What are the pros and cons? What do you use in your clinic?
So, I come from Nethradhama Eye Hospital, Bangalore, India, and ours is a high-volume cataract and refractive surgery center. We offer both Phaco as well as Femto to our patients. And I would say in terms of the ratio, the percentage, when we started Femto technology, we got the Femto technology in our institute in 2014. Our Femto numbers were actually probably just like 10% of the total cataract surgeries. But now, over the past few years, it's almost 40 to 45%. So you can see every year there's a steady growth in the number of Femto procedures that we are doing, and that's probably because of our patients asking for more and more premium lenses, the toric lenses and the multifocal lenses, which we all know, do better when there's a well-centered and a regular capsulotomy, which certainly is only possible with Femto always, and not with Phaco always.
Great.
Yeah, that's very interesting. That's actually what I was going to touch on, what you would attribute that increase to. And it does make sense, there's so much talk about, toric IOLs and all the more premium IOLs. Great.
Yeah, so what would you see as some of the major pros and cons of Femto and Phaco?
Yeah, so I think I'll just discuss the pros and cons of Femto technology, because if I discuss the...
We'll be here all
we could go forever.
the entire 10 minutes of the interview will be consumed. All right, so Femto, of course, there are lots of advantages. I personally love to do Femto procedures. That's because the most important advantage that this technology has to offer is customization. So you can customize the capsulotomy, whatever size you want, you can program it wherever you want. You want it to be centered on the pupil, on the limbus, on the capsular bag. Sometimes you have subluxated cataracts, so you want a decentered capsulotomy, so that's only possible with the Femto. And also nowadays the newer platforms, they are coming up with the customization of the fragmentation based on the nuclear density.
Right.
So they grade the nucleus density, and accordingly they plan the chops.
Yeah.
So it's not surgeons basically headache to kind of plan 4 chops or 6 chops or 8 chops. So the laser does by itself, and also the AIs, the arcuate incisions. They're such a big advantage. I have a talk today. I'll be talking.
Yeah, I think we're going to get into that a little bit later.
Yeah.
Yeah, well, I was just going back to the Femto laser, and you talked about the chopper. So does that, if you have this Femto laser, do you need less tools or devices? Can you do the chopping with the laser, or do you still need the chopper to get through those denser cataracts?
I think up to grade 2 to 3 nuclear sclerosis, cataracts, it does very well. You really do not need an additional instrument. Of course, you need a chopper to gently separate it though, but in very soft grade cataracts you can actually use an OVD cannula and separate it just with the OVD. So we have described this technique and we have also published it. It's called the visco chop.
Okay.
Yeah,
Wow, nice.
That's interesting.
Yeah, I have a paper on it.
Oh.
And
that's
for this very soft cataracts. You really do not need a second instrument. Yeah, but definitely grade 4 and grade 5 cataracts, those very hard brown, blackish cataracts where the posterior plate is really thick
Right.
Sometimes the laser does not penetrate that deep,
Yeah.
so you do need instruments and additional manipulation.
Yeah.
Okay, very good.
Let's shift gears a little bit here because I think this is a topic that a lot of cataract and refractive surgeons are curious about. Let's talk about people with astigmatism preoperatively.
Yeah.
So what kind of options do you have for pre-op, people with pre-op astigmatism?
Yeah, so as we all know that preoperative astigmatism of one diopter and more is so common. Almost 47% patients come with astigmatism, and this is so important to correct, especially if the patient is going for premium IOL again. You cannot leave the patient with residual astigmatism of anything more than 0.4 diopter because they're going to have a bad quality of vision. So there are different options that you can choose from. The easiest is to actually just place the incision on the steep axis, but sometimes it can be a bit challenging, especially if the axis or the meridian of the cylinder is an oblique one, and you have to make an incision from the temporonasal side. It's a little challenging. Then you also have the option of opposite clear corneal incisions. And of course, time-tested technology of LRIs, the manual LRIs, they are very much in place and still widely practiced. Yeah.
So I guess the other option is going to be toric IOLs. So
Definitely.
So how do you choose between each?
Yeah. I think the most important factor that you have to consider is the amount or the degree of the preoperative astigmatism. So our LRIs or the femto aquate incisions, they work well up to 1.5 to a max of 2 diopters of
the
astigmatism.
lower
The lower
astigmatism.
astigmatism, yeah. But anything more than 1.5 or 2, I think definitely we should go for torics because they offer a stable and much more predictable results.
Right.
Yeah, great. So let's zoom out again. So we've talked about, femto laser for astigmatism and things like that. What do you think is the future for both phaco and femto? I mean, do you see one becoming much more common in use, or do you think there's room in the market or in the treatment space for both?
I think for now, both technologies are very much in, and depending upon the surgeons' expertise and availability of resources, they with both the femto as well as phaco are being practiced. But I think I just saw the results of a recent survey, and it showed that there has been a steady growth in the number of femto procedures by 1.6% every year.
Wow.
So what I can see is that over a few more years, maybe a decade or so, I probably, the femto procedures are going to be more in numbers, and they're going to probably take over phaco. But phaco is always the gold standard.
Yeah.
It will always stay.
I hear a lot of chatter about the cost of femto. And I mean,
Yeah, definitely. I think that's the main limitation of the technology.
Yeah. Now, I mean, you do most of your work in India, which is revolutionizing, low-cost medical devices and things like that. Is there something on the horizon in India, maybe for lower-cost femto machines, to make this more accessible, or what do you think about that? What do you know?
I really don't think so. Any femto laser machine is, cost effective compared to others. But the high-end machines actually can do a lot. The machine that we are using is the Lensar, and it also offers us marks for toric placement, so like IOLs. So
You don't have to do manual marking.
No. We don't have to do any manual marking. No ink required.
Right. Okay.
No markerless system required.
Yeah.
So that's one
So
big advantage.
often these femto lasers come with more than just the laser.
Yes.
Yeah, they come with a suite of maybe software and other tools that can really,
Yeah, so thanks for coming on the show. Is there anything else you'd like to add today?
I think just one message to the young generation, the young phaco surgeons: do not ignore astigmatism. It's so important to treat astigmatism, and even if it's because cataract surgery is not just cataract surgery now; it's cataract refractive surgery. Patients want uncorrected 20/20 vision. So whatever works in your hands, the best, maybe manual LRIs, or if you have access to Femto or whatever. Just, do not ignore this. Try to correct it so that you can have happy patients and better patient satisfaction.
Great. Well, thanks again for coming on.